So good evening everyone, and after this exciting panel which generated a lot of controversy, we are going to talk about newer surgical techniques which are improving outcomes in lung cancer patients. The time given to me is only 7 minutes, so I'll have to rush through this, and I'm sorry that I'll not be able to cover the entire spectrum. So are we detecting lung cancer early? Yes. Screening programs in the Western world and also the widely use of CT scan like we saw during the COVID-19 pandemic has brought to our notice more and more patients with lung cancer. And these early and potentially resectable lung cancers are now throwing up some unusual questions which we did not face very often in the past. Can we do lung sparing surgery? What type of lymph node dissection should we do for these earlier stage cancers? How do we optimize surgical treatment with patients with low respiratory capacity or elderly patients? And how do we compare these modalities with non-surgical therapy? So now the shift is not only looking at oncological outcomes, but also looking at other outcomes like quality of life, physical function, and how the patient is living rather than how long the patient is living. Smaller is anyway better. It's in terms of incisions, resections, length of stay, and this has been possible because of improved anesthesia, because of ERAS, the thrust on prehabilitation, and also not to forget our newer surgical tools like the high definition camera systems, robotics, and stapling devices. So surgery for lung cancer has really come a long way from 1933 when Graham performed the first left pneumonectomy, and now this is what we have in our armamentarium for surgery for the primary as well as the lymph nodes. The gold standard remains lobectomy, but we can do a lot more and a lot less. So coming to the extent of surgery, what is the standard? This was established in 1995 when a randomized controlled trial performed by the lung cancer study group showed that less than lobectomy was associated with increased failure, and this established lobectomy as the gold standard in 1995. But there has been growing interest in sublobar resections, and this has been promoted by changing epidemiology, the cigarettes that people smoke now, faster and better CT scanners, and an aging population which demands a more improved outcome with surgery, especially because there are no reasonable alternatives yet which compare head-to-head with surgical management. So this is a SEER database which was reviewed in 2005, almost 15,000 patients, and no difference in survival when you compare lobectomy with segmentectomy in age above 70. And this was the much touted trial of the decade by Asamura, a phase 3 non-inferiority trial which compared segmentectomy versus lobectomy, published 2 years ago with 1,100 patients, and they saw that this non-inferiority trial actually proved to be a superiority trial with the segmentectomy group doing much better. There was higher leak rate with segmentectomy, and the improvement in lung function was not expected, but the survival was much better. Again, the Americans, they compared lobectomy versus sublobar resection, and again here, sublobar resections, including wedges, did not fare too badly when compared to a lobectomy, and this was seen in patients with tumors less than 2 centimeters. So is segmentectomy ready for prime time? Not as yet, and not widespread, because less than 1% of our patients actually present in first stage. There is a need for extensive tools such as pre-operative reconstruction software, multiple lymph nodes to be sent for frozen for margins, meticulous lymph node sampling, intraoperative identification techniques, and especially if you are adopting minimally invasive surgery, this has a steep learning curve. Anyway, it is now indicated only for peripheral and less than 2 centimeter tumors. Another problem that we are now facing is the central lung cancers. Now, usually these were considered as inoperable, and they were referred to our radiation colleagues for giving chemotherapy and radiation. But more and more patients are now being treated surgically using techniques which preserve parenchyma, either doing sleeve lobectomies with the bronchus or the facets. And especially this is very useful for patients who are unfit for pneumonectomy. Especially we should avoid pneumonectomy because that itself has a lot of physiological and cardiovascular problems. So when we have looked at sleeve resections, complications as well as survival, the 30-day mortality favors sleeve lobectomies and the survival is almost equivalent. So that was about the surgery for the primary. We also have to address lymph nodes, and the Mokels meta-analysis said that systematic mediastinal lymph node dissection improves survival. But now this is being increasingly challenged when we are facing tumors which are less than 2 centimeters, doing segmentectomies and wedge lobe resections. And here there is something which is coming up known as the lobe-specific nodal dissection, and it provides equal survival compared to the systematic nodal dissection. Surgical approach is another thing that has been debated on for more than 3 decades now, and it is more or less established that the short-term outcomes are much better with minimally invasive surgery in terms of post-op pain, recovery, less hospital stay, quality of life with a better lymph node yield and at least oncological equal outcomes. This was again established by a randomized control trial published just last year, where the physical function at 1 year as well as the pain, fewer serious adverse events, everything remained better at 1 year when you did a video-assisted thoracoscopic lobectomy. The other kid on the block, which is not as new now, is robot. And with the robot, the largest series was actually published almost 6 years ago with a 90-day mortality of only 0.5% and impressive survivals. Several other series continue to be published, and especially in the United States, there has been an exponential rise of more than 200% in the uptake of robotic surgery for lung cancer, but in developing nations, cost remains the biggest barrier. So, concluding, surgery is the original targeted and personalized therapy. Lobectomy still remains the gold standard for surgical treatment of early lung cancer. Segmentectomy and sleeve resections are here to stay. Minimally invasive approaches offer better outcomes, and systematic mediastinal lymphadenectomy continues to offer better survival. Of course, there are emerging modalities in imaging as well as localization techniques with smaller and smaller nodules being detected, and also surgery assisted synergistic therapy in the form of photodynamic therapy and microwave and cryoablations. So I'll stop here, just short of my time allotted to me. Thank you. I'll be happy to take any questions.